This is the first lecture in the Practice of Cardiac Sonography 1 unit. The title of this lecture is Essential Aspects of Professional Practice and Echocardiographic Imaging. The contents of the lecture are 1. Essential aspects of professional practice, including equipment handling, patient positioning, and patient privacy. 2. Imaging conventions. And 3. Parasternal imaging. There are 3 lecture learning outcomes. Following this lecture, you'll be able to employ relevant sonographer and patient positioning techniques, identify important aspects of patient privacy and echocardiographic imaging conventions, and also apply appropriate transducer positioning and alignment in the acquisition of echocardiographic images. Chapter 2 of Essential Echocardiography includes information related to parts 2 and 3 of this lecture, while the Code of Conduct document from the Australian Sonographers Association that is available via Views has information related to part 1 of this lecture. One, some aspects of professional practice. Sonographer positioning, or ergonomics. A well-balanced, stable and comfortable imaging position is important in the short and long term. Ideally, a cardiac sonographer should be positioned on the left-hand side of the patient, be seated wherever possible, assume a stable position, and assume a comfortable position. The illustration at the bottom of this slide is meant to reinforce the value of a good seated posture, wherein the weight is evenly distributed, avoiding unnecessary strain. Shoulder stability is also important. The muscles and soft tissue of the neck and shoulders are susceptible to injury if shoulder stability is not maintained. The shoulders should be kept as close as possible to a neutral, that is a resting position, and as such they should be kept even in height. They should not be rolled forward or in an abducted position for too long. Another important aspect of sonographer ergonomics is the transducer grip. When holding the transducer, aim to support its weight evenly, avoid holding it too firmly, and change the grip at regular intervals. In short, good sonographer ergonomics includes constant awareness of one's posture when imaging, taking regular breaks, which may be as simple as stepping out of the room between patients, and maintaining good general fitness and strength. It's best, on the other hand, to try to avoid unnecessary bending, prolonged twisting, or prolonged reaching. Handling and using equipment. No working environment is ideal. Nonetheless, aiming to make the best use of the environment in which you work will be helpful. Ideally, an imaging environment should include an appropriate sized room, suitable flooring that allows easy movement of chairs and machines, good ventilation and temperature control, and adjustable lighting. A couch that is height adjustable, movable, and has an apical cutout, and a chair that is height adjustable, movable, and swivels make it easier to acquire quality images. Modern ultrasound machines have been designed with features that not only enable acquisition of high quality images, but that also helps sonographers maintain good posture. Learning how to adjust the monitor, the control platform and keyboard will make imaging more comfortable, as will utilising places to store and hang transducers and ECG cables. At times, sonographers are required to perform examinations in environments that are difficult, like intensive care, for example. As such, at these times I recommend that you regularly adjust your posture, particularly if you are imaging for an extended time. Try to identify aspects that can be improved and seek help when needed from nursing staff, for example. And support yourself if you are in an awkward position, for example by moving against the bed with your elbow or hip, and take short breaks where possible. Patient privacy is an essential aspect of professional practice. As echocardiographic examinations involve close contact with patients, it's important to treat everyone in a respectful and considerate and polite manner. As a matter of respect for privacy, I suggest you always provide female patients with a patient gown. Be mindful of people's cultural and religious preferences. Invite and allow family to accompany patients when it's possible. And of course, avoid situations that would compromise the patient or yourself. With children and adolescents, be clear and straightforward about what is needed. That is, keep explanations simple. Be clear about what's involved and be willing to answer their questions. Seek to involve the patient's parent or guardian, especially if they are unsure or uncomfortable. For patients with special needs, similar rules apply. Respect and understanding need to be shown. Be very clear about what is involved. Be willing to rearrange equipment, avoiding unnecessarily long exams as well. And again, seek to involve the parent or guardian, especially if the patient's movement or understanding is limited. Imaging conventions. The heart can be seen from certain points on the chest, abdomen and neck. However, from other points it can't be seen because the ribs, sternum and or lungs obscure the view by obstructing the passage of ultrasound waves. The points from which the heart can be seen are called windows because the ultrasound waves can travel from the probe at these points to the heart and back, and as such provide a window to the heart. There are 4 standard echocardiographic imaging windows. They are the left parasternal, the apical, subcostal and suprasternal windows. Patient positioning is an important part of all echocardiographic examinations, and slight repositioning is usually required throughout an examination. Correct positioning helps to ensure that images are as clear as possible. For parasternal and apical images, patients should be positioned in the left lateral decubitus position. Decubitus is a Latin word that means lying down. When lying down for an echo, the patient should be reclined at approximately 45 degrees. Their left arm should be extended without unnecessary shoulder discomfort. And this position helps to ensure that the heart is brought into a position closer to the chest wall and therefore closer to the probe to optimize imaging. By convention, a standard echocardiographic exam starts with images from the parasternal position. Images are acquired from the parasternal position by placing the transducer in the third, fourth or fifth left intercostal space. Apical images are typically acquired after parasternal images. For apical images, the transducer is placed in approximately the fifth or sixth intercostal space in the mid-axillary region. An apical impulse may be felt at the point where apical imaging is optimal. The supine position is the next way patients are asked to lie for a transthoracic exam. The supine position involves lying flat, face up, with the arms by the side. It may also be more comfortable and help in the acquisition of images if patients are slightly inclined with their knees bent. Subcostal and suprasternal images are acquired with the patient lying supine. Subcostal images, typically acquired prior to suprasternal images, are acquired by placing the transducer in the midline or slightly to the right of the midline under the subxiphoid process. Suprasternal images are acquired by placing the transducer in the supraclavicular fossa and aided by asking the patient to tilt their head or neck backwards. By convention, in adult echocardiography, structures closest to the transducer are shown at the top of the display, and structures furthest from the transducer at the bottom. In the near field are structures near the transducer, in the far field structures further away. As such, apical images, like the images on the right of this slide, are displayed with the ventricles at the top, as they are nearer to the transducer, and the atria at the bottom. Specific terms are used to refer to the way the imaging probe is manipulated when imaging. Movement refers to a change in location of the probe. Tilt refers to an upward or downward pivoting motion of the probe from a fixed point. Angle refers to the side-by-side motion of the probe from a fixed point, and rotation refers to moving the probe around its axis at a fixed point. Parasternal imaging. The parasternal position is where echocardiographic examinations routinely begin. For parasternal images, patients assume the left lateral decubitus position, and images are acquired with the transducer at the left parasternal edge in the third, fourth or fifth intercostal space. From the parasternal position, two kinds of images are acquired. One, parasternal long axis images. Secondly, parasternal short axis images. The parasternal long axis view. As mentioned, for parasternal images, the transducer is positioned at the left parasternal edge in the third, fourth or fifth intercostal space. It's also necessary to ensure that the transducer is correctly aligned. That is, all transducers have an image marker. The image marker indicates the part of the scan plane that will appear on the right of the display. For parasternal long axis images, the image marker is pointed towards the patient's right shoulder, that is, at about 11 o'clock. When the transducer is correctly aligned, parasternal long axis images have the following orientation. At the top of the sector there will be anterior structures, at the bottom of the sector posterior structures. To the right of the sector will be superior structures, and to the left of the sector, more inferior structures. In Principles of Cardiac Sonography 1, Lecture 1, it was mentioned that the long axis plane extends from the left ventricular apex through the aortic valve. So, an image in a plane that extends from the left ventricular apex through the aortic valve from the parasternal position should appear similar to this image. The image shows numerous structures. 2 of the 3 aortic valve cusps should be seen, the right coronary cusp and non-coronary cusp. The aortic root and part of the ascending aorta may also be seen. The 2 mitral valve leaflets, the anterior and posterior leaflets, should be seen, and cords extending from the leaflets are often observed. The left atrium is seen posterior to the aorta. The coronary sinus and descending thoracic aorta may also be observed. Importantly, the left ventricular septum and posterior walls are seen at the base and mid-level in this long axis view. This is important as this view is most often used to measure the left ventricular wall thickness. It's also an important view for measuring the left ventricular chamber dimension. At the top of the display is the right ventricular outflow tract. Here's a single cardiac cycle loop of the parasternal long axis view. Clearly visible are the aortic valve cusps and mitral valve leaflets. The valve cusps and leaflets appear thin and mobile, which is normal. The aortic root and thin-walled left atrium can be seen. The muscular left ventricular septum and posterior walls are well seen, as is the basal and mid-LV chamber. Typically, this is the first image acquired in a transthoracic echocardiogram. By manipulating up the probe away from the standard parasternal long axis view, other views can be acquired. By tilting the face of the probe inferiorly, a right ventricular inflow view can be obtained. Structures that can be identified include the right atrium, the right ventricle, and the tricuspid valve, most often the anterior and posterior tricuspid valve leaflets. Here's a single cardiac cycle loop of the RV inflow view. By tilting the face of the probe superiorly, an RV outflow view can be obtained. Structures that can be identified include the right ventricular outflow tract, the pulmonary valve, and main pulmonary artery. Here's a single cardiac cycle loop of the RV outflow view from the parasternal long axis off-axis view. The parasternal short axis view. Parasternal short axis images are perpendicular, that is, at 90 degrees, to long axis images. The transducer remains positioned to the left parasternal edge, and then the probe is rotated 90 degrees clockwise until the image marker is pointing towards the patient's left shoulder, that is, at about 2 o'clock. From the parasternal short axis view, anterior structures are seen at the top of the sector. At the bottom of the sector, posterior structures. To the left of the sector will be right-sided structures, and to the right, left-sided structures. So, with the probe angled superiorly, structures at the level of the aortic valve can be imaged. Along with the aortic valve and its 3 cusps, other structures include the right atrium, tricuspid valve, right ventricular outflow tract, pulmonary valve and left atrium. By angling the face of the probe inferiorly from the level of the aortic valve, a view of the left ventricle at the level of the mitral valve can be achieved. In this view, the anterior mitral valve leaflet is the uppermost mitral valve leaflet. By angling the face of the probe inferiorly again, a view of the left ventricle at the level of the papillary muscles can be achieved. In this view, the medial papillary muscle is near the middle of the image, and the lateral papillary muscle to the right. And by angling the face of the probe inferiorly again, a view of the LV towards its apex can be imaged. In conclusion, in this lecture we have considered sonographer positioning, good ergonomics, things to do and things to avoid. We considered some aspects of the important subject of patient privacy and professional behaviour. Next, imaging conventions were discussed, including patient positioning, how images are displayed, and the ways the imaging probe are manipulated. Finally, parasternal images were considered, probe positioning and alignment, together with important aspects of parasternal long axis and parasternal short axis imaging. Finally, at the end of this lecture, I've included a YouTube video entitled The Circle Survey. It is aimed to reinforce the content of the lecture and to show a technique which I'm sure you will find helpful in identifying and keeping the best parasternal and apical window.
So we're going to review some of the methods for beginning sonographers to really be able to help master the basics of echocardiography. One, the first place I like to start is what I call a circle survey and what some people call window shopping. We basically are looking to find the window. In this case, we can see there's definitely a window here, but what you can see is every once in a while, as I'm doing this circle, that the image gets very bright. One of the hardest parts for a sonographer that's very new to realize is how to get the best window, and then also how to get back to it, because you get very timid to move away from a window that you find because you're afraid that you might not be able to get that window back again. So this is a reasonable window here, but if I do a circle survey, all of a sudden I stumble into something. And the reason we use a circle is because with a circle you know exactly how to go back. If you're going up and down, side to side, you may not remember exactly which combination you used to land in a window. But if you use a circle, then you can see that if you pass something, you can back right up in your circle and find it again. So again, I'll circle around, that's bright. If I back up, there it is. I'll go past it, I can back up, there it is. So even if we're circling the other way, there's a good window. I go past, that's not good. I can go back counterclockwise or however you're moving, and then you can find your best window again. So the circle survey really helps stumble into the best possible window and feel confident that you can go back and find what you passed, so you're not tethered down to one window that may not be the best window for a particular patient. And like it is in this particular case, a little bit of work leaving my comfort zone of something that I had can stumble me into a nicer window, and I can just back right into it. I'll do the same for the apical view. First thing I'm going to start doing is start circling around. And okay, so you can see we're getting close. So I'm going to make the circle smaller in the area where I'm closing in on it. And if I pass, I can just back up on the circle, and then I can fall back into my view. So again, by circling around, see how big the movements are, very gross with my hand, and you can see what's changing on the screen as well. Just back up a little bit after I've passed something that's bright, and then go into the nicer view, and now I can make my more minute manipulations to get and fine-tune an image. But it's very easy to end up in a place where you're working, and it's not a good window, and if you just take a little circle survey or go window shopping, you may stumble into a better view. But if you're moving in that predictable manner, it's very easy to get back to where you were if you're always moving in that circle. So that's the circle survey. Let's go window shopping and have better images every day.